so I'll kick us off. Hello, everybody. My name is Ida. And I thank you very much for joining this discussion, which is extremely important. You will get a thorough introduction to all of the guests, but may I just say that we have a really wonderful array of speakers across the global health leadership spectrum, to people who work every day with young women, with parents, and who ensure that, you know, the best health solutions come to people. There's never been as much talk about vaccines as right now. And in fact, for the past 2 to 3 years, vaccines have been certainly the most prominent health media story, if not one of the most prominent discussions on the global news agenda, but not the HPV vaccine. And that really is a problem, because it's a highly effective vaccine and women are dying needlessly because of cervical cancer. This is why we put forward this discussion in partnership with the Sabin Vaccine Institute. And excitingly, this dialogue comes to you in part from Bangkok, where a major conference is underway, where our moderator Jaya Sridhar is attending, and also senior leadership and other speakers on this call are attending, listening, brainstorming, discussing issues around zero-dose vaccination, how to bridge the incredible gap and the backslide that has unfortunately happened in the COVID-19 period, and also very specifically the HPV vaccine and or how to prevent cervical cancer. So I look forward to the discussion very, very much. I thank you so much for joining. I think you'll be able to take a lot from it. We'll talk a little bit about story grants that we have on offer. There will be resources for journalists to follow, and we will certainly also follow up with all of you who've joined today, because we have your email addresses and we can stay in touch with you. And most importantly, remember to ask questions, to put forward your questions in the chat. We'll keep a lookout for them. And also there'll be an opportunity to ask those questions live, because that's what journalism is about, is wanting to know answers. And we have a lot of people with good knowledge and good expertise, and, you know, who are so invested in helping the world understand better about HPV vaccination. So I'll pass now to our moderator, Dr. Jaya Sridhar. She's also a senior health media advisor at Internews, my colleague. She is talking to us from Bangkok, and she will introduce our guests and kick off the discussion. Thank you, Jaya.
Thanks, Ida. And I'd like to just start off by thanking the Sabin Vaccine Institute for so generously supporting this media dialogue. And the goal of Internews is public health work, as many of the journalists who've joined this conversation already know, is to support journalists to engage audiences with evidence-based storytelling skills about health, hold those in power to account, shape and change norms, and manage health and misinformation. And all of these goals seem like near perfect guideposts for journalists to tell the story of HPV vaccination, a story it looks like its time has come. So welcome everyone to A Shot of Truth, an untold story of hope against cervical cancer. This is a global media dialogue on HPV vaccination brought to you from Bangkok, from the front lines of the second annual conference of the Vaccination Acceptance Research Network, VAN, supported by the Sabin Vaccine Institute and co-convened with UNICEF and co-sponsored by Gavi, the Vaccine Alliance. So this is a moment in time where we stand at the beginning of a concerted global push to make HPV vaccination accessible for anyone who is eligible all over the world. And the WHO has designated prevention through HPV vaccination as one of the pillars of the global strategy for the elimination of cervical cancer. So as we know, cervical cancer is the 4th most common cancer among women. It killed more than 340,000 women in 2020, a tragedy that could have been averted considering that we've had a safe and effective vaccine to prevent cervical cancer for well over a decade. So most cervical cancers are associated, as we know, with infection with a certain type of virus, certain types of a virus known as the human papillomavirus, or HPV for short. And vaccines against HPV can prevent most cases of cervical cancer, but only if the vaccine is given to girls and women before they're exposed to the virus, which usually happens via intimate physical contact, mostly during sex. But as we know, again, HPV vaccination is scarce in many countries despite this life-saving potential. And vaccines are limited and expensive in low-income nations, and misinformation about the vaccine is preventing people from getting it. So we do need to improve public awareness about the vaccine and improve access to vaccination, which is already compromised by fragile vaccination delivery systems. So in today's event, we have a two-part dialogue. And in the first part, we'll focus on the existing evidence and rationale behind this global push for HPV vaccination. And we'll also hear key observations on the current state of the initiatives that are underway. We'll be hearing in this section from 3 technical experts, all of whom have devoted considerable energy to promote evidence, equity-based strategies in the HPV vaccination effort. So please join me in welcoming Anuradha Gupta, President of Global Immunization, Sabin Vaccine Institute. Also, Charles Kakaire, Social and Behavior Change Specialist for Immunization Demand at UNICEF headquarters, and Vaibhav Gupta, who's a global health and public policy expert practitioner leading advocacy and partnerships at B Medical Systems, a private enterprise reputed for its cold chain expertise. So thank you all so much for taking time to be with us today and for your outstanding work. In part 2 of this dialogue, we're going to explore answers to some key questions. What are the winning strategies and behavioral interventions that are helping communities understand and accept HPV vaccination? How should journalists communicate the evidence for HPV vaccination, and how should media and civil society organizations hold decision makers to account? So to share experiences and insights from the front lines on all this and more, we're delighted to welcome youth health and women's rights advocate from South Africa, Y-isha Raphael. Also, Dorothy Logedi from Kenya, who is a nurse practitioner and community immunization advocate, and journalists who are passionate about gender and health and who've earned a name for themselves for their reporting on the gendered aspects of health. We have Maitri Porecha, Senior Assistant Editor from the Hindu newspaper, India. We have Esther Nakkazi, Founder Director of the Health Journalists Network of Uganda, and Salma Eldeeb, journalist, science communicator, and clinician from Egypt. So I'm going to turn to Anuradha very quickly to set the context. As we know, routine immunization for children, childhood immunization rather, suffered a steep decline during COVID. And World Immunization Week in April this year marked the beginning of a year-long campaign called the Big Catch-Up, representing a global effort to vaccinate millions of children and return to pre-pandemic vaccination levels. So we do know there's widespread awareness about childhood vaccination, but there's little public knowledge about vaccination recommended for adolescents and young adults, particularly against the human papillomavirus. So some countries like India notably are gearing up to procure millions of doses and roll out HPV vaccination on a massive scale. And public health experts like you are talking about the need to have a strong platform to mainstream HPV vaccination and make it available to all eligible young people, mainly girls. So what is the evidence to support that recommendation? Over to you, Anuradha.
So thank you, Jia. I'm delighted to be here and have this opportunity to speak to colleagues from media. So you have already actually said a lot. But let me just again reiterate a few important data points on HPV and cervical cancer. So human papilloma virus, we popularly call it HPV, actually is a cause of cervical cancer among women. HPV also leads to other kinds of cancers, also among men, but the incidence is low. For example, cancers of head, neck, and penis. But also in case of women, it is mainly cervical cancer, but there can be other kinds of cancer too. And of course, we shed a lot of light on cervical cancer because, as Jia rightly stated, the cervical cancer cases have gone up during the past few years, and also cervical cancer related deaths have been on the rise. So to just give you some data on this, in 1990, there were less than 185,000 women who were dying of cervical cancer every year. And now, in 2020, the number of women dying from cervical cancer has shot up to more than 340,000 women per year. So you can see the jump in mortality because of cervical cancer. So now we have every year new infections, cervical cancer infections, up to 600,000. So 600,000 new infections and 340,000 women dying of cervical cancer. And what is even more scary is the fact that 90% of these cervical cancer deaths actually happen in low and middle income countries. And why so? Because the incidence of cervical cancer in lower income countries is actually much, much higher than in rich countries. And then, of course, because in lower income countries, screening and treatment facilities are also lacking. Therefore, you know, when women get precancerous lesions, they are not screened in time, they are not treated in time, and you have full-blown cases of cervical cancer, and then it is very difficult, you know, for first treatment facilities are not available to the desired extent, but even where they're available, the cost of cancer treatment, as you know, is prohibitively high, and therefore, you know, you find that mortality from cervical cancer is really rising to alarming levels. I would also want to state that a number of women dying of cervical cancer actually are in the prime of their youth. So really the age group is from 19 to 45 years of age. And you can imagine the social and economic costs of losing young women, because when women are mothers and they have young children to look after, and those young children are orphaned because of untimely death of their mother, you know, the costs are just really, both the human costs and other costs are just, you know, very high, and they're preventable, right? They're avoidable, because as Jia said, we have a vaccine which is highly effective, very effective. And this was actually developed and approved for use way back in 2006. And it is really therefore sad and unfortunate that so many years after the vaccine became available for one of the cancers. We know that vaccines are largely for infectious diseases, right? And it is only two vaccines that actually help prevent cancers. You know, one is hepatitis B, you know, which actually helps prevent lung cancer liver cancer. And the other is HPV vaccine, which helps prevent cervical cancer. So, and you know that for other cancers, there is no vaccine at the moment. So I think so this is an opportunity, right? For both for liver cancer and for HPV cancer to really use a vaccine to prevent morbidity, mortality, and catastrophic medical expenditures that typically push so many families and people into extreme poverty every year. So that's really the sort of the background for this. Now, just a couple of more reflections. You know, countries that account for 60% of cervical cancer burden are yet to introduce the HPV vaccine. So clearly that is an important objective in front of us. You know, how do we work with these countries in order to get the vaccine introduced? And let me also clarify that when I say that the HPV vaccine is yet to be introduced, that really means that the vaccine is yet to be introduced in the national immunization program, publicly funded program, where, you know, people can access it free of charge. As you know, vaccines are offered, you know, through public provision, free of charge. They are not priced, and people don't have to pay for them. They may be out-of-pocket expenses, right, involved in travel, etc., but people are not charged for vaccine. But in a lot of countries where the governments haven't moved forward to introduce HPV vaccine in their national immunization program, HPV vaccine is available in private market. For example, in India, HPV vaccine is very much available in private market, and the private doctors are prescribing it, and a lot of girls take it. But then it is only the rich who can afford the high price of that vaccine, who are getting the benefit of this. And really the poorer populations who are at a higher risk and who have a cost barrier actually cannot benefit from this vaccine. So in a way, it is acute inequity, in those countries where cervical cancer burden is very high, but the government hasn't introduced this vaccine as a part of the national immunization program. So that is one aspect of the issue. And the second part of the problem is that in countries where HPV vaccine has been introduced, there have been a lot of challenges with regard to its acceptance and uptake. So again, to share some data with you, actually globally, the coverage of young girls with 2 doses of HPV vaccine is just 12%. Before the pandemic, it was 15%. Now it is down to 12% because, as you know, schools closed down, and in general, vaccination services received a setback during the pandemic. However, with first dose, now there is a SAGE WHO recommendation that 1 dose of HPV vaccine is also sufficient to provide protection to girls against cervical cancer. But then even first dose coverage is just 15%. Pre-pandemic, it was 20%. It is now down to 15%. So clearly there are serious and formidable challenges on vaccine acceptance side, which need to be unpacked. Now, they do vary from country to country, right? In some countries, there's a religious sort of belief. In some other countries, we have seen some sorts of rumors and misperceptions and misrepresentation about this vaccine. But overall, we have to recognize that there is a challenge. So what is that, therefore, as the conversation about women's health and about the benefit of this vaccine is gaining momentum sort of after the pandemic, we have at the Sabin Vaccine Institute been thinking a lot with our partners about what is needed in order to really combat this situation. And therefore we came together with a lot of, and Vaibhav is here representing the medical systems, but there are several other partners who actually came together to give it a serious reflection. And we decided to set up the first public-private consortium called the Global HPV Consortium. We've just put this together, the whole idea, and it would be officially launched on September 5 in Kuala Lumpur in Malaysia. And we really are hoping to build up a lot of support for this consortium in due course, with national governments on board. But what is the distinguishing feature about this consortium? And I think that really touches at the heart of what we need to do differently going forward on HPV vaccination. The first thing that we are saying is that public and private sector players have to come together. So we have the civil society working with us, but we also need to engage with our private sector in order to bring our full energy behind this agenda. The second, and I think that's a very important thing to keep in mind, is that vaccination, which is primary prevention, has to go hand in hand with secondary prevention, which is early screening and treatment of precancerous lesions. Because if we are serious about eliminating cervical cancer as a public health concern, which is really WHO's whole strategy, then it just can't be vaccination alone without a conversation about early screening and treatment. And we also think it's a good strategy, not just from public health point of view, but also from community confidence point of view, because when you are taking a much more holistic approach to an issue that the community is confronted with, their trust in public health institution goes up, because they begin to believe that the government and other institutions are truly invested in their holistic health and well-being, and not just in one strategy, which is just vaccines and vaccination. The third thing that we are emphasizing through this consortium is really the urgent need to harness the potential of adolescents and young men and women, youth, right? Because I have personally heard adolescents say a lot, nothing about us without us. And because adolescents are typically a healthy segment of population, there is very little interaction between adolescents and the health systems. And therefore it is extremely, we have 1.8 billion adolescents and young men and women now in the world, a lot of them in Asia and Africa, because Asia and Africa, as you know, have a larger share of younger population. And it is extremely important that we engage with adolescents and young people, which health sector hasn't done, as I said, traditionally, and really bring them on board and use them and their creative energy to situate HPV as a part of a broader strategy aimed at ensuring adolescent health and well-being. So that's, and then finally the women groups. It is a women health issue, you know. So men are carriers of HPV, but they pass it on to women. So finally, women are the victims of this disease. And of course, as I said, men may have some sorts of cancers, but that incidence is very small compared to cervical cancer. So therefore, it is a women. And how do we, and one of our focus, this thing would be to actually engage with grassroots level women organizations and really make it into a movement at the community level, where community concerns are understood, they are recognized, and they are really addressed in time, so that people start to have much greater faith in the power of this vaccine. So with that, Jaya, I will pause.
You flagged a whole plethora of issues. I think I can think of so many story ideas that came out of your a very comprehensive overview, not the least of which is offering single point interventions like just immunization alone may not be appreciated by communities, as well as having cervical cancer screening and management and showing that one cares for their health more than anything else. So, and you also flagged up this interesting part about private sector participation, which brings us to someone who's here from the private sector. We have Vaibhav with us. As Anuradha talked about, a consortium and a strong global platform to push HPV vaccination, get it out to the people who need it, and its benefits can potentially become evident right from pre-adolescence to old age. But how do we get to that point? I mean, governments and health systems grapple with integrating HPV vaccination into service delivery, and there are a number of infrastructural challenges that many countries face, for instance, in the cold chain, which is your area of expertise. So how does one go about reporting on these issues? How does one go about getting a clear idea of some of the health system challenges that need to be addressed before we can talk about getting to the last mile with HPV vaccination? Vaibhav.
Thanks, Jaya. So firstly, I mean, a big thank you to Sabin and Internews, and glad to be here. You know, it's, I think Anuradha has, you know, laid out the issue really well. And maybe, you know, I'm going to assume that people understand cold chain a little bit, but it's a fairly esoteric subject. So, you know, simply, basically, what do we mean by cold chain, right? It's essentially about maintaining appropriate temperatures for a number of health commodities which are temperature sensitive. So there are vaccines, of course. You know, from COVID-19, we know that vaccines need to be stored and transported at certain temperatures. But there's also other commodities. There's insulin, there is oxytocin, there is other kinds of medicines, there is blood and blood's components. The HPV vaccine itself also needs to be stored and transported at 2 to 8 degrees. When we think about expanding coverage for HPV from, let's say, 12% to 90% or more, we do need to consider whether countries and specific pockets within those countries have adequate and appropriate cold chain or not. During COVID-19, a number of countries, of course, were able to strengthen their cold chain. But I think there are, still a number of gaps, especially when we consider that, apart from HPV, there are a number of other vaccines which are being developed, right? And as we think about sort of life course immunization and adults being vaccinated, the cold chain piece becomes actually very, very important. And I'd like to make maybe, 3 kind of specific points. One is really from an investment perspective. Now, as I mentioned, it's not just for vaccines, it's also for blood, it's for other essential commodities. And when you look at the whole landscape in terms of, lives saved, the wastage prevented by having the right cold chain, by reduced morbidity, then the rate of return actually on this kind of investment is extremely high. And, especially when you consider that it's not just human vaccines which could be carried through the cold chain, but also animal vaccines. So I think that is one perspective. I think the second part is really around access and equity. So let's talk about, last mile a little bit. So often a lot of communities, marginalized communities, remote communities, which don't receive these kind of services, also suffer because, the cold chain is inadequate. Fortunately, we have now technologies which allow us to use cold chain to extend health services to the last mile. I think a lot of us would have heard about, drones being used to carry vaccines now. We are working with some drone companies to develop boxes which can, keep the adequate temperatures. We're also working on, we've developed refrigerated vehicles, which are specifically, again, designed to carry these vaccines and temperature commodities. So we have, there is that technology to really take vaccines and other essential commodities to the last mile, right? And then you can just imagine the kind of impact it can have on lives saved. So very important from an equity perspective. A slightly different lens on equity when we consider frontline health workers. We know a lot of our health workers, frontline health workers, are women, right? And it is they who end up carrying a lot of the boxes, right? I mean, in very remote areas, they often have to carry the boxes with vaccines inside them. And they can be quite heavy, these boxes. And we've received, again, a number of requests from governments to develop lighter boxes for so that, women find it easier to carry. It may not seem much, but it's really important. I mean, if you go and talk to some of the women frontline health workers and their experiences, they will tell you every extra thing that they have to carry is a huge burden, right? And it's the difference between being able to carry out, vaccination appropriately. So equity is the second lens. The third piece that I want to emphasize is from a sustainability perspective, right? Maybe some of you know, maybe you don't. Cold chain, can be quite environmentally damaging. There is, so now, there is, again, technology which allows us to extend cold chain, which is, green, which is environmentally friendly. There is a technology called solar direct drives, which are essentially, help us to use solar panels to maintain the cold chain, but without use of batteries, right? There is also a lot of work which is going into materials which help us maintain temperatures more efficiently. And finally, the use of green refrigerants. So, so just to kind of recap, right? Cold chain, if you strengthen cold chain, it's good for health systems, it's good for equity, it's good for the environment, right? I think the challenge has been that cold chain, unfortunately, does not evoke the same emotional response as a topical area, right? I mean, when we talk about maternal and child health, when we talk about disease verticals, it's more tangible. People can hold on to it. Cold chain kind of cuts across the system. And I think, if there is one message I would like to give to this audience is that next time you're in the field covering a story or talking to people who are working on immunization, go behind the scenes a little bit and see what is actually the supporting ecosystem to make sure that those vaccines and health commodities reach the last mile. So that's my 2 cents. Thank you.
Thanks, Vaibhav. I mean, I could just sort of see some visuals playing out in my head. The drones carrying the ice boxes with vaccines to the last mile, and lighter designed boxes for women health workers to make it easier for them to carry, being sensitive to their needs. And I think we've seen a few cold chain stories in the media, but it's not a hot media favorite, as you say. But you made this interesting point about how investing in the cold chain actually is a beneficial public health intervention that cuts across many areas of public health. You can use it to deliver other kinds of vaccines and maybe adapt it for carrying blood and so on. So this reminded me of the time that incinerators that were given to burn the needles and so on in hospitals actually helped improve the level of keeping it sterile and infection free. So I think this would be really a valuable investment and good to do stories on cold chain and strengthening health systems, equipping them better to carry HPV vaccination to the last mile. But we've sort of gotten the global context about where different countries are with rolling out HPV vaccination. And we looked at an important aspect of the health system to carry vaccinations to the last mile. And now we're going to look at, with all of this in place, with the fancy strategies, policies, programs, investments, and so on, what are we left with as far as communities are concerned? Do they want the vaccine? So what is the demand like? And this is where we turn to Charles Kakaire, who is a demand specialist, in the area of immunization. So what is it, Charles, that's happening what's the temperature out there in the communities? Do communities want the HPV vaccination? Do some communities embrace it more easily than others? Can you tell us what is going on in the field?
Thank you very much, Jaya. Thanks, Anuradha and the previous speaker. Jaya, HPV vaccine, just like any other vaccines, its acceptance and uptake entirely depends on the principle around trust. That's the overarching principle around the uptake and acceptance of any vaccine. Now, this could be trust in the vaccine itself, but it could also be trust in the system that's delivering the vaccine. That's one point that I wanted to make. The second point, Jaya, is that while the HPV vaccine is for adolescent girls, there's different stakeholders in this. That is also another thing that really makes the HPV vaccine a bit different. The adolescent girls themselves, who are the main target of the vaccine, the parents of those girls, who most times have to give consent before the vaccine is given, the teachers. We know that most of the HPV rollout programs are school-based. Teachers are very crucial in the process. Healthcare workers who actually administer the vaccines are another key stakeholder within this, as well as the community leaders. So effective strategies for building uptake and acceptance of the HPV vaccine can only come into play when there are strategies that engage all those different stakeholders. Each of them has a big contribution to make or to the end result, which is uptake of vaccines. Now, from the evidence that we have, all data pretty much shows that effective communication strategies include those that both educate the population about the HPV vaccine, but also specifically those that facilitate decision-making around vaccine uptake. And in all these, the third element really is the fact that for all, whatever you do in terms of communication, you need to ensure that there's community ownership of the vaccination process. So those are sort of, that's sort of a three-tier system. Now, to be able to do this, Jaya, we go through a process. Every time you see an effective communication intervention, there's some science behind it, which is always informed by the evidence. One of the things that we're doing as UNICEF, but also the partners that are working in this field, is to collect social data. By social data, basically, the beginning point for a communication intervention really is to be able to understand what are the social and behavioral drivers of any vaccine uptake, be it HPV vaccine, be it COVID-19, or be it all the other vaccines. Now, unless we're able to listen, to the concerns, the fears, the rumors, the misinformation out there, that each of these different audiences that I talked about hears, faces, or experiences, we are not able to design effective interventions. So, to come back to your question about what are we seeing, what is it that needs to be done, there's a lot of work that's going on. Again, there's very good examples of of work that has gone on, from the process of collecting social behavior data to working with the communities, especially the girls themselves, to co-design interventions that are informed by the evidence that comes from the social and behavioral driver studies, using that information to design those strategies with the target audience for whom the communication interventions are geared to, and ensuring that that links to the national programs, for rollout of these interventions. We also know, Jaya, from the evidence, that communication interventions that are targeted towards community leaders and healthcare workers are being seen to be very effective. We know that interventions that target both the girls themselves as recipients of the vaccine, but the parents who have a key stake to make in their decision, in their consent to do that, have been found to be effective. But also, most importantly, Jaya, a lot of the vaccination programs, HPV vaccine programs, are school-based programs. Teachers, and again, there's evidence everywhere that students have a lot of trust in teachers. Now, unless we build the confidence, around HPV within that constituent, we're not able to have an effective, program that moves. And lastly, last but not least, the community leaders as well. While most of the programs are school-based, we also know that there's a lot of girls, especially in low and middle-income countries, who are out of school. Now, in ensuring that those are not left out, there's also a concerted effort that we have to put in place to ensure that there's a mechanism to reach them. So those are sort of the different tiers, that have to be looked at in terms of ensuring this. I just, of course, I'll come back to this later, but the media is another important key stakeholder in this. I'm glad that we have this conversation, Jaya, and we will be able to see how best, again, we can all work together, from the supply to the demand and to the policy, to ensure that we're all working towards the main objective, which is increasing the uptake and acceptance of the HPV vaccine. Thank you.
Thanks, Charles. I mean, it sounds like a whole range of stakeholders, starting with the parents. Like if the policy is to vaccinate 9 to 12-year-olds, for instance, clearly parents have to make that decision for the children. and teachers are involved, community leaders are involved, religious leaders are involved. So in many ways, this reminds me of all the stakeholders that needed to come on board for COVID-19 vaccination to take place. But this seems to be vastly more complicated because the people who are going to be the primary recipients of this vaccine are going to be underage, 9 to 12-year-olds. So this is informed consent is going to become, I think, a big story in the media. And I think journalists, will have to do a lot of work, keeping in close, really go into the field to see what's happening and work with people like you. And Dorothy, whom I'm going to lead to better understand issues around uptake. Dorothy, you've been in the field in Kenya as a nurse practitioner, working with the HPV vaccination rollout in communities. And what do you feel, what are the winning strategies that are helping community uptake and acceptance of HPV vaccines? And what are the deterrents that you've come across? And can you share a case study or two as well? Over to you, Dorothy. Dorothy, can you hear me? Okay, I'm not sure if Dorothy, you'll have to unmute yourself. Yeah.
Okay.
Yeah.
Thank you. In Kenya, we started we started HPV vaccination in the year 2019 in October. In 2019 October, whereby we were targeting girls from the year 9 years to 10 years. This was due to the HPV vaccine. In the field of COVID vaccine, in the field of HPV vaccine, we target the girls who are mainly in school, and these are the girls who we have to target them in school so that we may not have inconveniencing them from coming from school to the hospital. So we were moving to the schools to vaccinate them. Then here come the COVID-19, interrupted everything, and the schools closed for 6 months. This made us not to proceed. We had that defaulter, and that is why our percentage had to go down, because the second doses, the uptake was now poor. And now on that note, the strategy which are being used is just still go to school. We have the registers, we go to school and do the vaccination in school, and not
Dorothy, you're muted again.
The challenges we get from the community, this is from the churches, from the misconception from the parents, that any vaccine introduced to the girls that is having contraceptive, and that is what is hindering the uptake of the children who are not in school, because already they have been convinced by the parents that any vaccine which is given to girls, and mark you, HPV is only given to girls, it's not given even to boys. So that gave them powerful reason to say it is having contraceptive. So it is very important for the community person to advocate the importance of HPV vaccine. And also what we get in the community, that so long as that vaccine is given, they complain it is having contraceptive. Again, the churches have a very negative attitude on vaccines. All the ones coming in the field, the churches always say this one has such and such a component which is going to affect the health of the community. Also, culture is playing a very big role in hindering the uptake of HPV vaccine. So if we can really know how we can deal with the culture, the religious, and lack of knowledge, who their knowledge is low, they don't understand what is cancer infection. They think cancer infection is like malaria, like pneumonia. They don't know the system, how it affects the system, and which part of the system is more important there to be protected. They really have that small knowledge on cancer. And when you tell them it is on that mouth or the entrance of to the uterus, they really don't understand this entrance to the uterus. How is it? But those who have knowledge, whereby their educational level is from standard 8 going onwards, they really understand something on the cervix. So lack of knowledge, educational level, misconception, religious factors, it really hinders the uptake of the COVID vaccination. So if we are going to make the uptake to be up, let us deal with traditional culture, then we deal with education, we educate more on the cervix. They don't know the reproductive organ. They don't know what the cervix is and how is it important. Then here comes also behavior change.
Yeah, Dorothy, thank you so much. I think, yeah, I'm sorry to cut in, but I'll come back to you. And it looks like a whole bunch of stakeholders need to come on board. We need to situate HPV vaccine advocacy and promote acceptance in a cultural and religious context, and also among populations where vaccine literacy is low. So there's a huge role for journalists here. But Dorothy flagged up this really interesting gender angle, and I'd like to go to Y-isha right now, whose work Y-isha has been with young women and based on health and human rights. And how do you position HPV vaccination within the work that you're doing in terms of advocacy for the health of young women? Y-isha, over to you.
Thank you, Jaya, and thank you for everybody who's joined the meeting today and who's listening and watching from home. I think what I would start with is saying that, and at the risk of repeating what has already been said, but I think it is important, the first and most important steps in supporting and encouraging young women is for stakeholders and healthcare providers to engage extremely meaningfully with parents and caregivers about what the HPV vaccine does for the female body. Young women need to be educated extensively about HPV and the health risks of not being vaccinated, and as well to understand the nature of the virus and its effects on the reproductive systems of women. We need to reach young women and young people where they are, as I mentioned before, by breaking that first barrier of uncertainty from parents and caregivers, as a lot of parents and caregivers who are uninformed and unaware about the dangers of HPV believe that a vaccine will only encourage promiscuity. And there's still huge stigma from the larger community towards young women about conversations around sexual and reproductive health. So more recently as well, there's also the issue of increased vaccine hesitancy since the rollout of the COVID-19 vaccine in the last 3 years. So that also contributes to reduce understanding and awareness. So rolling out campaigns that stimulate conversations that are reproductive for young women's understanding of their sexual and reproductive health are so important. We need to utilize more non-traditional media platforms and on-the-ground advocates to spread the message to the wider audiences of young women and stimulate the demand for more vaccine rollouts in more communities and the larger spheres of the population. So there needs to be a focus as well on the vaccinations of young men. As much as they are not as severely affected by the virus as women are, they also contribute greatly to the spread of HPV. Young men must be involved in engagement and conversation and be included in vaccine rollouts, especially in lower income countries. In the first round of vaccinations, actually in South Africa, which were in 2014, there was a coverage rate of 83%. But during COVID, that actually dropped to 3%. And as much as we are now recovering from that, we've only reached the 30% coverage with our recent vaccination rollouts for 2020 to 2023. Now, in South Africa as well, the government only subsidizes these vaccinations for young women and girls aged 9 to 16. And for other sections of the population, the vaccine needs to be sought out privately at an extreme cost with consideration to current economic and social situations of young people. Now, lastly, I just want to say that stakeholders and healthcare providers must have the courage to converse with young women about the issues that affect our health so that we can make informed and confident decisions. Like was said earlier, there should be nothing about us without us.
Thanks, Y-isha. I mean, that was very powerfully said. And I think no matter how many times one says that phrase, repeats that phrase, it still, could be said one more time. I think, again, you flagged up a whole range of interesting issues for journalists to cover, positioning HPV vaccination as a right to health for young women. At the same time, the importance of bringing stakeholders on board and making them really understand the value of it for their children. So thanks for that. I do know that there are some questions in the chat that the panelists are welcome to answer by typing answers into the chat. But I think I will just open up one question to Anuradha. There's a question from Alphonse who says, what place does Africa occupy on the cervical cancer spectrum? And when did the whole WHO HPV vaccination initiative take off? Over to you, Anuradha.
Yeah, so Africa actually has the highest age-specific incidence rates of cervical cancer. So, yeah, because, if you look at just the absolute numbers, when I'm saying 600,000 new infections every year and 340,000 deaths, you can because Asia is supporting a much larger population in absolute numbers. Therefore, you would see that, in Asia, and within Asia, South Asia has a larger share of population. You could really see in absolute numbers, more infections and more deaths in Asia. But, if you look at the rates, which is the age-specific incidence rate, then Africa is the highest in the world. And therefore, it is extremely important that we pay a great deal of attention to both Africa, followed by Asia. So that's on. So far as the cervical cancer elimination initiative of WHO is concerned, this was 2018, if I recollect correctly. It was 2018 when Dr. Tedros actually sort of spoke about this whole issue of cervical cancer and actually made a call, right, to launch an initiative which focuses on elimination of cervical cancer as a public health concern. So you cannot reduce the number of cervical cases to zero, but you can definitely bring them down to a level where they cease to be a public health challenge or concern. So that's where they also spoke about primary vaccination and primary prevention and secondary prevention, which is really vaccination, but also screening and treatment.
And there's one more question for you, Anuradha, from Samuel Mutungire, who's asking about how does one tell the symptoms of cervical cancer apart from those of other STIs? Because women might get concerned that they have cervical cancer when in fact what they have is something like gonorrhea or another STI.
Yes.
Yeah.
So this will have to be, I would not hazard a guess here, Jaya, on the symptoms and on the so I think this is for really an expert, a medical expert to state, what exactly are the kind of symptoms that because, and so we can set up a conversation or, come back with a clarification on the kind of symptoms. Because as I said, there are typically precancerous lesions, and it is possible if there is early screening to detect it in time. And then, and I just want to clarify two things. There is now cost-effective screening that is possible and available at community level. It is called ascetic screening, where, it is vinegar-based and it's undertaken, and it is very easy to see that there is a possibility of a precancerous lesion. And then there is a simple procedure, which is called cryotherapy, where you sort of burn the precancerous lesion. So, and that's also cost effective, can be provided at the point of care at community level as a part of the primary healthcare delivery. Several countries have started to do it, but there is a need for countries to step up their investments in both early screening and treatment. And that can really prevent, as I said, full-blown cases of cervical cancer.
Thanks, Anuradha. And Samuel, I'll post something for you. I didn't want to take away from the conversation that's going to move to the very exciting area of stories that journalists can do. We have senior journalists here, but I'm going to respond to your answer in just a moment. But now that we've heard from frontline responders and the technical experts, I'd love to be able to move this conversation over to Maitri Porecha, senior assistant editor from The Hindu, who's been covering gender and health for a while now. And I just wanted to know, in countries like India, which are poised on one of the biggest HPV vaccination rollouts, what are the stories that we should be looking at? I do know that a number of areas have been flagged up, but with specific reference to India, we have Indian journalists in this webinar. What would you say are the high points, and what are the opportunities and the challenges? Over to you, Maitri.
A very good morning, afternoon, or evening, wherever you are in this part of the world. It's a good opportunity to discuss HPV vaccines. And I would like to start this narrative from 2023 we are in now. But let's go back to 2016 when New Delhi, one of the Delhi state ministers, Satyendra Jain, who was then the health minister of the state, had announced that about 1 to 1.5 lakh girls, in Delhi, particularly from class 6, will be the first ones to be given the HPV vaccines. And Delhi was the first state to undertake this under the public health program. After the announcement, we do not have any reports of follow-up to what happened to that program. Were the procurements made? Which companies were these procurements made from? The cost, as rightly Ms. Gupta had mentioned, are high. It's $121 for 3 doses. Now, to bring those costs down to as low to $2.5 to $4.5, Serum Institute, cut back to 2023, has in January made this announcement about its indigenous vaccine, and also added as a caveat that, once the Union Health Ministry floats a global tender to that effect, they will be able to supply those vaccines. Now, considering that Serum Institute of India is the only company which is providing these vaccines at a low rate, it will clearly have some sort of a leeway there. However, a lot of sources that we've spoken to, senior health officials in the ministry at this point, say that that tender has not been floated. So so we are clearly sort of delayed on the timelines. I don't know what's holding us up, but I think that's for us as journalists in India. I see, and I know a couple of us in the panel and those who are attending, to find out, but definitely, like I'm sure I'm going to file an RTI at least to that regard, and others are also welcome to file this. Like, it's not about it being an exclusive story or something, and I'm just very concerned about this fact, and that's why I'm putting it out there, as a mechanism to build pressure or just find out if that's going to happen, and I'm going to do that for sure. Now, so that said, this is how you report on it. Big numbers are being quoted. By 2025, 68 million girls will be vaccinated, but have 1 to 1.5 lakh girls from Delhi been vaccinated? Let's get an answer to that first from the state of Delhi, and let's not politicize it, but be it Delhi, be it the Union Health Ministry, they need to be more transparent about it. We have not asked these questions. Similarly, for the global tender, when Amit Shah went and inaugurated the Serum Institute of India, he went there. There was a story in PTI about this. There was a story about Satyendra Jain in Indian Express when he announced it. But what after they start announcing these things, right? Now, why it's particularly concerning for us is because of the 342,000 women who succumb to the disease globally. Nearly every fifth woman is dying from India, according to the Globocan data. 77,300 women have those kind of deaths have been reported, and the registries itself are weak. So we don't know if more women are dying, right? That's what I want to say. And lastly, I would want to say that WHO has said that it's 9 to 13 years that needs to be targeted. However, we need to know that these are minor girls. So be it in Delhi schools, or be it when center writes to states, like 6 states have first been asked to campaign. These states are Karnataka, Tamil Nadu, Mizoram, UP, Maharashtra, and Chhattisgarh, right? These are the 6 states where the action is. Now, I'm in Delhi. It's close to me. In UP, there are journalists here from Maharashtra. We can all try and find out in our own states as to whether this campaigns for readiness, and what kind of campaigns are these, in the light that these doses have only not come. So, Abhi, is the momentum still being built? We need those answers. We need experts on the panel here to tell us these things. And because it's minor girls, could we also, as a micro policy, say that, girls above 18 years could make a, could we do that in colleges? Like, why are we only targeting schools then? So if we are not able to make any breakthroughs with under 18 population, should we also simultaneously target the young population who are or may not have gotten sexually active in deeply rooted patriarchal societies like India, where maybe, the age at which a girl would get sexually active, I mean, it's a problematic statement to make, but we can just target all kinds of, populations out there, right? So teachers are being taken into confidence, but parents sometimes have issues. There are issues of rural and urban divide here. So, there are non-profits who are working in Maharashtra who will be able to cater to the rural population and say that, okay, a certain amount of, and there have been a beautiful article in Midday that Jane Borges has written about this. She's done a very good feature that I could find online. However, the article says that there is urban reluctance in elite population. So clearly, because, it's an invasive method, something's going inside your body. COVID happened, and then, the vaccine related side effects. So we need to talk about adverse events following immunization as well. It could be low, but there has to be reporting. There has to be transparency about this. And lastly, I would like to mention just two more points I would like to make before closing, is that the rural areas of Bihar, Jharkhand, Assam, West Bengal, and UP where there's a high population of lower socioeconomic groups in villages, the mortality amongst those women is high, and that's due to poor general hygiene, even water shortage, for that matter, or the refusal of men to wear condoms. Very basic sexual education is grossly lacking here. Now, how do we tackle that? That's also something that journalists can choose to focus on. There are like an array of story ideas that we can kind of focus on in cervical cancer area, both urban and rural. The last thing that I want to mention is diagnostics. So we know for now that pap smear is not as sensitive as the newly floated RT-PCR molecular tests, and that those tests, which were popularized during COVID, are therefore more sort of, like pinpoint the infections. But the overall percentage of women going for preventive pap smear or RT-PCR related molecular tests, which also require a vaginal swab to be taken to be processed in an RT-PCR machine, I think, and can be done probably like once in 3 years or once in 5 years, as and when like the recommendations for pap smear or these molecular tests are. And they just cost about rupees 1,000 to 2,000. So pap smear would be like 1,000 rupees and a molecular test 2,000 rupees. We have the infra. So by the time, like, you may think or maybe take the vaccine or not take the vaccine, but at least get the tests done every few years on your body, right? That's easy, right? So that's something journalists should look at amplifying, I guess. Yeah, thank you.
Thanks, Maitri. Again, there's your passion comes through, and it's clear that the overriding call is for more transparency and availability of information on the HPV vaccination rollout in the country. And I'm sure the situation is similar in many other countries where journalists aren't really privy to the nitty-gritty of the program. So I do remember that before COVID-19 vaccination was rolled out in India, there was a very clear media outreach effort on the part of the government, which brought on board several editors. And so the media was fully apprised of what was happening, and there were frequent briefings. But this being a highly sensitive issue, irresponsible reporting or reporting that raises questions for which the government doesn't really have answers at this point could well derail what is certainly a life-saving intervention for young women. But you flagged up important issues such as informed consent and the variability in vaccine literacy among rural populations and among the most disadvantaged communities. And I think these are great stories that journalists should do and ask the right questions. And it certainly argues for a very transparent communication strategy from the government and to keep the journalists informed and to make data and information available to them. I think that you flagged some really key issues. So this is going to be a very interesting story moving forward.
I'd just like to add one more thing here that I forgot to add. When 2016, the Aam Aadmi Party Chief Minister Arvind Kejriwal, who's fortunately still in power, he went to the hospital, when they were flagging this program, and he took his teenage daughter along. I think she was all of 16 or 18 at that time, and he made her have that jab. And that raised this point of controversy, which said, was this, some sort of positive publicity? But then, it really did send out a good message that, look, here the chief minister's daughter is taking it. So it kind of set the tempo there, but I don't know how widely that was reported. And then since the entire noise around this has kind of, so I just thought I should mention this because this was a very interesting nugget of information. Yeah.
Thank you for that. I mean, that would have sent a very, very powerful message. And to your point about why it's the younger age group that's sort of considered ideal to receive the vaccine, it's before, it's not just that, it's before they get exposed to the virus. So as we know, the age of sexual debut in countries around the world, we don't really have enough data and information about that. But there are some very good studies that show that the younger age group from around the age of 9 or so is probably a good time for the vaccine to be received. So that's based on some very sound, good ethnographic studies and good anthropological research. So that's where that recommendation comes from. I'm going to quickly move to Salma, who's going to answer some of the questions in the chat. But Salma, you're reporting from Egypt, and you're a science communicator and a clinician yourself, and you probably encounter a slightly different set of challenges when communicating about HPV vaccination to the public. There are cultural concerns, there are religious concerns that were also mentioned by Dorothy. So tell us about how you think, like, what should be the elements of good reporting on HPV vaccination from your perspective?
Okay, thank you for the opportunity to talk. So as Dorothy mentioned that there is severe lack of sexual and reproductive health awareness in Egypt. It's not only for females, it's only for males. So actually we are in a situation of Egypt that the basics of sexual and reproductive health are not covered. So we are too far away from like covering HPV. And the other aspect that actually HPV vaccine in Egypt, like when I went to take the vaccine, I was like 26, and they like said, are you under 26? Yes, because everyone above 26, they can't take the vaccine. And the next question that you ask, are you married or not? So if you are married, you are not allowed to take the vaccine. Although it is like high cost in Egypt, one dose can cost up to $40. So you can pay for $40 for one dose, but you cannot take it if you have like sexual intercourse or you had any previous sexual experience. So there is a lot of media uncoverage also about the HPV vaccine, because a lot of people are not, they don't have access to this information. And also they don't have access that cervical cancer can be prevented by taking the vaccine. So we don't have screening programs in Egypt for cervical vaccines. We only have for hepatitis B. And there is no specific part of screening for females. There is no breast cancer screening program, although we have like higher rate of breast cancer vaccine in Egypt. And I think, as far as I remember, it is the first one more common in Egypt. So we are dealing with the situation that we have a lot of barriers, like religious barriers, also media, the lack of media coverage, and also the basic knowledge of sexual and reproductive health. So I think the best way to like report about HPV in Egypt, that it should cover all these elements. Like you need to put yourself on the shoes of like female, has a sexual experience and wants to take the vaccine. What should this female do to can take the vaccine? So I think by that way, you can cover a lot of the struggle females face in Egypt. And also the most important thing also, I'm speaking on Egypt. So Cairo, I live in Cairo, which is more accessible to such like elite vaccine. So I think also it's most important to go for rural areas or Upper Egypt and ask people, do you have any idea about HPV, or do you have any idea about cervical cancer? Can it be protected or not? All of these elements must be covered when you are reporting about HPV vaccine. I wish I was clear.
You are, Salma. Thank you so much. And I can only appreciate what a challenge it must be to make sure that the conversations are respectful as well as informative and affirmative. So thank you so much for your inputs. I'm going to very quickly move to Esther now from Uganda. She's the founder director of the Journalists Network of Uganda. And I'm going to ask you, Esther, about what you feel is the Uganda perspective. Like, what has it been like to cover HPV vaccination in your country, and what lessons can you share with the other journalists on this call?
Thank you very much. I hope you hear me fine. And if I'm breaking, then I'll switch off my video. But I speak for Uganda, but I also speak, I think, for Africa in general. I think there's pretty much what Dorothy said, and most of the speakers who have talked about HPV and cervical cancer in Africa. There is that lack of understanding when you go to speak to sources. They really don't understand how HPV will stop cervical cancer. So the understanding that if you have a vaccine of HPV, then you will stop cervical cancer. I think that understanding is very, very, is not really, really clear. And then we have the issue of sexuality and values and how we talk about it and what is happening right now. I mean, I can't talk about it in detail, but all of you know that sexuality and how we think about it as Africans is very different from the way people want to think about it, or it has really evolved over time. We understand technology, we understand that the mobile phone does everything, but then when it gets to sexuality, there is a way we want to think about it and remain on the other side of the era. So we haven't evolved to come to terms with certain things. And we need to, I think we need to really tell people that the science has proven, the science is clear. The science is clear that if you have an HPV vaccine, then you will not catch cervical cancer. And then we also need to communicate very thoroughly that these young girls, these young children whom we are giving the vaccine, because when you go to the field, you hear all issues of, oh, my child is going to not have babies, or it will cause infertility, or it will, we need to explain this thoroughly and say the science is very clear. We need to, one of the editors talked about showing people who have actually had the vaccine and they have babies at the end of the day. So it does prevent the disease, but you will also have children. So we need to communicate the science more thoroughly and show that it happens. Then there's still that misconception that the children, once they have they will hear this, information about sex, and then they'll start having sex. And the age of sex debate is we start early. We know that there are communities that really, some young girls really start having sex early. So people should be comfortable with having the children get the vaccine. Anyway, it's not the vaccine that will inform them about sex. They already maybe have heard about sex, so they should have the vaccine and prevent. This is a preventable disease. It's one of the biggest killers here in Uganda for women. And every time you walk into these facilities, you feel sad. You really feel sad as a journalist, because it is preventable, as you have clearly communicated. We also need to have the policymakers, I think, understand and explain to people, or they need to put budgets, or they need to put a lot of campaigns in people understanding that prevention is better than cure, because the vaccine is available, it's free, it's there. Why is the uptake so low? Sometimes I think the governments are not paying a lot of attention to the prevention. They would rather go to and we've seen that for some issues, and there's a way they explain it. But also I want to appreciate the young lady who from South Africa. The advocacy for the vaccine, for me as a journalist, every time I'm trying to write stories, I look out for activists, people who will speak strongly, their voices are heard, and the advocates for HPV are still not very loud. You can hear HIV, you can hear all those diseases. When it comes to HPV, you're still looking for the people to speak for it. And the social and cultural norms have been talked about. And the last story I wrote about, the woman was like, oh, I heard about it on the radio, but I don't know where to go. And I fear the screening. So there are all those new diagnostics that have been talked about by other editors and what can be done at home. There is a self-test. I think we just need to bring this to the people to understand that they are available. Let them know that they can use them. Let them know that even the screening is not a difficult thing. It's not even painful, because all I heard from everybody that I interviewed that day was like, oh, they told me they'll go in there and do ABCD. And it's just not making sense sometimes. So from my experience, I think even if, sexuality is a big thing, which is the bigger thing in Africa, we know that we can still talk about this, and we know that sexuality has evolved elsewhere, and we know we can have conversations that are clear and tell people that your children need to be vaccinated, and when they hear this information, they are not just going to start sex. Thank you. Over to
Thank you, Esther. That was a fabulous roundup, I think. And again, you flagged a number of areas that the journalists need to concentrate on. I'm just looking at the time here. I think we began over an hour ago. And Sunny, how are we doing on time? Do we have time to take some of the questions in the Q&A box?
I think since we started about 5 minutes from the hour, so we've got we've got 10 minutes left. Yeah, so we can take at least one more question. Okay. Yeah, Anuradha, on.
Yeah, so I just wanted to come back with a comment on this age thing, right, which seems to be creating a lot of confusion. And I just want to clarify that the guidance, WHO guidance, is to really sort of vaccinate girls as soon as possible. And 9 years is the earliest that the girl should be. So that's just the right age, and that's not before 9. But if you do it, for every vaccine, there is an age that is prescribed, and that's the ideal age. So we always say that there are certain vaccines which should be given at birth because they have higher protection, right? Similarly, some vaccines are given at 6, 10, 14 weeks, most of them, actually most, just 6, 10, 14, because that's really the ideal time to give that, because they have then maximum protection and effectiveness. Similarly, measles first dose is 9 months, yellow fever is 9 months, then second dose is 18 months. And it doesn't mean that all children receive those vaccines at the right time. Some of them get delayed, some of them receive. And then the recommendation is, of course, you should give, delayed vaccination rather than denying vaccination. So coming back to HPV, 9 years is really the earliest, and because that's the time when girls now have started to attain puberty. Now you can argue that some girls attain puberty at 9, some at 9.5 years, 10, 11. But it's really more about sort of saying, okay, this seems to be the right age for girls in general. But then it is 9 to 12 years, and really the recommendation is 9 to 26 years. So if girls actually miss that window and girls don't get vaccinated, and parents start to, or girls themselves become aware of this vaccine and the benefits of this vaccine later, then up to 26 years of age, this vaccine can be administered and is recommended. But beyond 26, and now the age has been enhanced to 45 years, and the recommendation is that, it should be discussed with doctor, with concerns to understand the benefits, because in some cultures, right, in some cases, people may change their partners. They may get remarried, after a certain age, and then they are exposed to a new kind of risk. So I think coming back to this whole issue about countries must take a decision about appropriate age based on their own context, right? Based on their, so if in a country or in a culture, girls do not become sexually active at a very young age, then of course the view can be taken to push it, say, to 10 years, 11 years, 12 years. But these are very difficult to determine sort of factors. So it's always good to err on the safer side and just say, look, 9 years is fine. But I just wanted to come back on this age thing. And this is not to married women should not be denied. Married women, but the point is that if they have already been exposed to HPV virus, then the protection that the vaccine would actually give them can significantly reduce. And these days, there is a supply constraint, right? So HPV vaccine is in short supply, and that could be one of the reasons why in some countries, younger girls, unmarried girls are being prioritized. But as I said, the recommendation does not debar married women or women of a higher age from getting this vaccine.
Thank you so much, Anuradha, for providing those clarifications. I do know that there's, I'm seeing from all the chat and messages in the chat and from the Q&A that there's quite a lot of interest in following this issue and getting a better understanding of the evidence that's out there. And I'm grateful to Vince, who's been providing a lot of links and to more information that's out there. And also to Sunny, who's connecting people to our AJN resources and so on. But I think this is a great start. This is a conversation that hopefully we'll keep, coming back to in the months to come as HPV vaccination gets underway in many countries, particularly India. So I think this is a really great start, and I'm very grateful to all the panelists and the journalists who've participated and for the wonderful questions that have come in. So I'm not going to give any grand wrap-up remarks because I think everything that needs to be said in this preliminary part of this hopefully longer conversation has been said, but I'm going to quickly turn it over to Ida and Sunny to sort of wrap up.
Thank you so much, Jaya. That has been so exciting to follow the discussion. And I was particularly pleased with many of the comments in the chat, journalists saying they're learning so much. It's an opportunity to find out more about an area that they hadn't reported on before. So I'm glad, journalists on the line, that you are finding that. And so before we close, I just wanted to let you know that we will invite your story suggestions on HPV vaccination, and perhaps so that you're eligible for a small number of story grants we will have in terms of a program we're doing with the Sabin Vaccine Institute with journalists who are following our Let's Talk Vaccines course. And I'll ask my colleagues to, in fact, post that link in the chat as well. So keep engaged with our health journalism network. You'll see the link in the chat. Keep on looking out for story opportunities, opportunities to report on new topics like this one. There will be something specific on the HPV grants I mentioned to you now. And, thank you for joining us. And I'll pass over to Sunny. I want to thank all of my colleagues and once again, everyone from the Sabin Vaccine Institute, of course, Anuradha, and other colleagues we have engaged with. Thank you, Sunny.
Right. Thank you very much, Ida. And before we end, I'd like to extend our deepest appreciation to the Sabin Vaccine Institute, especially to Vince Blesser and Nadia Piambert for working with us in Internews to make this webinar possible at the sidelines of the second VAN conference in Bangkok. My heartfelt thanks also goes to all the speakers and panelists. Thank you for accepting to take part in this webinar at such short notice. It's much appreciated. A special thanks also goes to Internews Health Director Megan Miller for her support, and to my health team members, Ida, Dr. Jaya, Michael, Christoph, Adele, Bea, and Kath. A special thank you too. You guys are great. Yeah. Before I close this webinar, please remember to download the HPV and cervical cancer resource for journalists. The link is in the chat. And do contact us for further details on the Media Fellowship grants. And with this, I take the opportunity to close this webinar. Have a good rest of the evening at the VAN conference if you're coming from there. Thank you very much and hope to see you soon. Thank you. Bye-bye.
Thank you.
Thanks, everyone.
Thanks,
Bye-bye.
colleagues. Bye.
Thank you.
Thank you. Bye.